Welcome to my presentation about LiVRSono, a virtual reality training with haptics for intraoperative ultrasound. Ultrasound in general requires visual spatial skills. Based on the current position of the ultrasound probe and the current ultrasound image showing a cross-section, the physician has to create a mental model of the interior structures. And without these skills, it is very difficult to interpret ultrasound images and to orient within the 3D anatomy, and these skills can only be trained hands-on. Then there's also intraoperative ultrasound, which means the ultrasound is used during surgery and directly on the organ, which you can see here in case of liver surgery. And liver was also the use case for our prototype. In this case, we have the same challenge regarding the required skills, so now the position is directly on the liver, and the mental model is quite difficult because of the complex vasculature and interpersonal variations. There is one more challenge that makes VR training essential for intraoperative ultrasound. As mentioned before, ultrasound can only be trained hands-on, but it is not possible during surgery at the open patient. So we analyzed relevant skills with liver surgeons and defined and implemented 4 training scenarios in a VR training application. And the basic functionality of this training application can be seen in this video, so the user can move the ultrasound probe on the liver, and on the right side there's an ultrasound monitor with the real-time ultrasound simulation. So the application can be divided into these 2 parts, so first the ultrasound simulation itself and then the training environment. When simulating ultrasound images, there's always the challenge of having a fast but also realistic and physically correct simulation. There are different methods, and we decided on using a texture-based approach. The advantage of this is that it's quite fast, which is necessary for real-time simulation in a VR application. For the simulation, we already got the segmented 3D models from the surgeons, and we used them to create a 3D render texture. This has to be done once per liver case and is not possible in real time. Then we used different shaders to create the ultrasound-specific image section, to add artifacts and physical effects, and then we got this resulting ultrasound image. As input device, we used a grounded haptic device with force feedback. This is quite important in our case because in reality the probe is also slightly pressed on the liver surface, and it would be very difficult to move the probe on the liver surface in the VR application without feedback or resistance. And to have a more realistic feeling and hand position, we printed an attachment to simulate an ultrasound probe, which is the black part. There are also several training applications in various medical areas, however most of them do not focus on the visual spatial skills, and these which do so are either desktop-based or use simple geometric scenes. Because of this, we want to make sure that the real situation regarding hand-eye coordination is given in the VR environment, and we aimed at identifying relevant training scenarios for visual spatial skills that are also medically relevant. So we defined 4 training scenarios with medical experts, and the first 2 are based on the intraoperative workflow, whereas the last 2 directly focus on the 2D, 3D understanding. In the first scenario, the user has to scan all liver segments. There's a common classification that divides the liver in 8 segments, and the user has to identify which one they're currently scanning. So in this case, only segment 4 and 5 are active, and this classification is always based on the underlying vessels. So the user has to get an overview, and then they have to state which one they're currently scanning. In the second training scenario, the user has to find and trace relevant vessels. There's a so-called hepatic vein star, where 3 large veins emerge. And in the task, the user has to find this anatomical landmark, and then they have to find the beginning of one of the 3 veins, state which one they want to trace, and tracing means that the vein has to be in the middle of the ultrasound image or directly under this red arrow. It's quite difficult to see, but there's a small horizontal vein the user is currently tracing. In the third scenario, they have to identify the liver they are currently scanning, and so in this case the liver in the patient is hidden, and the user has to select a correct liver based on the interior structure and not based on the outer appearance. They can grab them, and then they have to identify the correct one based on the vessels and the metastasis or tumors. In the last scenario, there's an ultrasound image given and they have to reproduce it. So this requires the understanding of the shown cross-section and probe handling. So there's the position and the rotation are checked, and they can also get some hints. So the position can be shown by a sphere on the liver, and the rotation can be shown by a ghost view of the ultrasound probe. We evaluated our application with 11 liver surgeons, 6 experts regarding intraoperative ultrasound, 3 novice and 2 without experience, so we had 5 potential users of this training application. In the first part of the evaluation, they were asked how realistic or plausible the setting, ultrasound probe, haptic feedback and ultrasound image are. Although the setting, probe and image are not completely realistic, they were rated quite positively and is appropriate for the learning objective. The haptic was rated not that positive because of jittering and a limited range of movement of the device. In the second part, they had to assess the learning scenarios, so they were asked how meaningful and effective the scenarios are for the learning objective. The first and the third training scenarios, so the one with the segments and the models, achieved good results. The second one is also good and meaningful, but here the implementation should be changed. And the last one, reproducing the ultrasound image, is not meaningful because it's never necessary to reproduce a specific ultrasound image. Additionally, we conducted a small pilot study regarding learning outcome. Therefore, we had 6 non-medical participants, and this limited number was because we want to reserve the target group. They had 3 training sessions with 4 tasks of training scenario 3, so the one with the liver model which was rated best and does not require medical knowledge. In a pre and a post test, we recorded errors and time per task, and each of the tests consists of 12 tasks. And we also used the competence item of the intrinsic motivation inventory. 3 participants had no errors in the pre as well as post test, and the other 3 participants reduced their errors. Additionally, to reduce or constant errors, 5 participants were also fast in the post test by 13 seconds on average per liver scan. And 1 participant had an increased duration in the post-test. However, this person reduced their errors from 4 to 1, which is more important than being fast in our case. The competence also increased from pre to post-test, and additional questions as well as comments emphasized the perceived improvement and perceived learning effect. Despite of a ceiling effect as well as limited implication of the study, positive effects are visible, which we want to investigate in future studies. In conclusion, we analyzed the learning goal and intraoperative workflow in close cooperation with medical experts. Then we identified and implemented 4 training scenarios, whereof 3 were rated as meaningful and effective. Finally, we evaluated the prototype with experts with varying experience to assess phase and content validity, and a pilot study for learning outcome. In the future, we first want to improve, for example, the ultrasound image by sharpening the edges and change the implementation of some training scenarios. And after these minor changes, we want to conduct a larger study to assess, for example, the construct validity, the learning outcome, as well as the learning transfer.